the mic is on. They're not, they'll go on.
I'm Chapman, North Central ICH. Good morning, North Central.
Great, thank you. We are still have a microphone issue. Charlie wants to go. Oh, am I the only one not plugged in? Is it someone trying to tell me something?
I will do that. Take pictures.
Why we're getting that feedback.
Yeah.
Yeah. That's right.
That's the one that we don't think has a plug-in.
Turn that one on.
Oh, he's moving. No.
Seems to be working out now.
That one's not feedback, so.
We can use this one. Your MP is, that's fine. This one won't work.
Is everyone else on? Doing a trial for Rosalinda?
Ours is just gonna.
It's on. Can you guys hear us online?
We can barely hear you. This is Sheila.
Thank you, Sheila. We're working on it. Fun. So while we're working on it here, why don't we get those who are online to introduce yourselves?
Sheila Chilson, Moses Lake Community Health Center.
Richard Donaldson and Naya Flint from Samaritan Healthcare.
Hi, this is Susanna Palmentier, Cooper Medical Center.
Hi, this is
Tracy
Karen
Miller.
Jacobson from Family Health Center.
Tracy Miller, Mid Valley Clinic.
Anyone else online that we have missed? Okay.
Wendy, can you make sure we hear you now that your mic's on?
Can you hear me now that my mic is on? Better, or is it still quiet?
It sounds good.
Thank you.
When did we have one more?
Can you introduce yourself?
Dave Coley, Compounds.
Welcome. Are we ready? Do you have the PowerPoint? Do you have the agenda in front of you? And get a motion to approve the agenda?
I so move.
Thanks, Rosalinda. Second?
A second.
Thanks, Loretta. All in favor?
Aye.
All opposed? You have the minutes from last month. We were up in Okanagan. And can I get a motion to approve the minutes?
Make a motion to approve the minutes.
Thanks, Mr. Chris. Second? Thanks, Blake. All in favor?
Aye.
All opposed? All right. Announcements. So immediately following this meeting, JD Fisher and Rachel Quit, Healthcare Authority, will be here starting at 1 to give a presentation on value-based payment and multi-payer and the rural multi-payer model. And we encourage you all to stay to hear what they have to say. They're going to show the BBP results, survey results. If you participated in the results, I think in the survey, I think all but 2 organizations from our region actually participated in that survey. So you can see the results. That's a statewide survey that they did, and we'll be presenting those results. They're also talking about the VBP and moving forward with how will you be entering value-based purchasing in the future and what your needs are. So encourage your attendance and to vocalize what you're needing. It's your opportunity to ask questions and vocalize the needs that you may have. Any questions on that? Then I would like to announce the NCACH Summit is coming up on Friday, April 12th. It'll be at the ATEC building, which is at the Big Bend Community College in Moses Lake. And there should be more information in your packet on that. If you're interested on who should attend, and if you have any additional questions, feel free to reach out to me or Sahara. She's not here at the moment, but probably will be later. If you have any questions or want to register, if you look on my email below my signature line, there's a link that says register for the summit if you haven't done so already and you're interested in attendance. Great. Anything else? Announcements? Okay. Talk briefly about the learning activities that we have coming up so everyone's on the same page. We have the motivational interviewing workshops that are this week. We have the first one is tomorrow and Wednesday in Okanagan. And then we have a second one, which is on April 4th and 5th, which is Thursday and Friday in Moses Lake at Grant Integrated. Good morning. No, you're fine. Don't apologize. It's all good. Do you want to introduce yourself?
Lisa Apple with Okanagan Behavioral Health Care. Hi, sorry I'm late.
There you go.
Can I ask a question on the summit?
Sure.
In terms of us figuring out who to send, how much information or content will there be involved in the current initiatives?
Very little.
Very little? Okay. Good to know.
Any other questions? Okay. So they have motivational interview workshop is this week, and then we have the quality improvement affinity group. You do not have to have attended a quality improvement workshop. If you're involved in quality improvement, have questions about what you're doing, or just want to get involved, feel free to join in. It's April 25th from 12 to 1. It's an online call. The call-in information is on the portal calendar. If you need assistance getting into that, just let me know. And then we have a motivational interview and train the trainer. So if you've gone through the motivational interviewing training, whether we have put it on or in the past, and you're interested in that, if you haven't heard from us on those prerequisites, please let me know and I'll get more information. If you're interested in doing the train the trainer, there are a few requirements to be able to participate. That's a 4-day training in June here in Wenatchee. And 2 new workshops that we have coming up. The first one is for behavioral health. It is the team roles for primary care integration in behavioral health workshop. We have room at the moment for 6, possibly 7 organizations who are interested in that. I believe we can only fit 2 to 3 people. They're looking for a team from your organization. It can only be 2 to 3 people. Someone asked, and I think it may have been Mr. Chris, if they could send 4. And I'm still confirming, but due to space and the amount of teams, I think they're limited to 2 or 3. 2 to 3. The AIM Center from UW is actually the one who is conducting, John Kearns and 2 of his associates are coming in to conduct that training, and we are doing that jointly with Better Health Together in Spokane. So we're looking at 5-6 teams, potentially 7, and they're looking at 4 to 5 teams. So it could be some time to network too with colleagues around the state, or at least Eastern Washington. The other one, we've heard from several of you individually as well through the QI Affinity Group, I believe, when we had that topic come up on patient and family voice and quality improvement. So we've put together that workshop. That will be on May 30th at 8:30 or 4. This is like hot off the press, so I will have more details coming out soon to you if you're interested in that. We're working on getting that registration link, but I will get a syllabus and agenda out to you very soon for you to register. And that workshop will be here in Wenatchee also. It's just a one-day workshop. Any questions on any of the learning activities workshops I talked about? Okay. Many of you did participate in the learning activity capacity sharing survey. I appreciate that. And I'm going to save that survey for Roger. Roger will discuss those results so that it ties in with the other conversations that we've been having with Roger's leadership series. So I've kind of put that with him and let him lead that conversation. And I think now we're ready. Just to preface this, Chris emailed and asked if they had some information they wanted to share, and at the same time we were talking internally about having WPCC partners share something at each meeting, some of their successes. There's a lot of good things happening right now around the region, and we really want to get that out there. And so then Chris said, hey, can I share? And this was back in January, you asked, but we had Dr. Manriquez in February, then we were in Okanagan in March, and so we have him today to share on their crisis data. So I'd like to invite him.
Actually, I'm going to turn it over to Eric Skansgard, who oversees our crisis services, and let him talk about this because he's the one that's been working on this data.
Great.
I apologize to the people on the phone. I'm grabbing a laser pointer right now, which I will use at times. I'm assuming that screen right there will probably be the one that I need to go on, if that works for people. So I won't be able to, unfortunately, if you're on the phone, I don't know if you'll see the laser pointer piece of that.
You won't. But Eric, can I have you come sit by Chris so you're by a microphone?
Certainly.
Please.
I may have to turn around.
Do you want him to stand and click the slides from you?
Thank you.
You have either place, Eric, there or where Caroline's at, and use that microphone. Your choice.
I'll use that.
Not that microphone.
That's tall. I may have to point at the screen here. You're going to be able to. There's just do it from here. Okay, perfect. All right, so Eric Skansgard, Capital Charities, I want to thank you all for the opportunity to present. It's always a good thing when we have a chance to tell good stories. And I also want to acknowledge all of the transitional care and diversion intervention work group team that I see around here. This is similar in some ways to what they do. Some of the things that we're working on. Basically, the services that are happening to improve continuity of care and reduce unnecessary utilization of services at higher levels of care. As Paul Harvey would say famously, kind of the rest of the story, if you will. It turns out that our early warning system tends to track high utilization locations such as involuntary treatment detentions, Parkside coming on recently. I think there's been a great interest in individuals who are winding up in that level of care. What we're wanting to do, though, is make sure that you hear that there's more to that. For every one of those services, there's a huge amount of activity that's happening out in the community. So that's really what we're going to talk about. I want to start by going into the past just a little bit, kind of where we were. When I came here in 2014, what you're looking at right now these are the utilization rates for Eastern State Hospital that happened back in 2014. And I want to emphasize with the pointer that you can see one of the big issues that we needed to correct was we had a lot of people at Eastern State Hospital, and we needed to not do that. We were at 150% of our utilization capacity at that point in time. relative to the other RSNs at that time, Spokane and Greater Columbia, we were much greater. We initiated essentially what amount to diversion practices, kind of a paradigm, identify the gaps that are out there in the community, and then what are we going to do and how are we going to address those. And even though the Eastern State utilization rate seems less relevant today, it does reflect the paradigm, and we continue to use that to try to target services for individuals in the community, and thereby reducing some of the higher end, more costly, and sometimes stigmatizing services that happen. So as you can see, we'll move forward for those. You can see that we went from, from first to first. So relative to our other regional support network, BHO, MCO, as of 2017, we had dropped down to a utilization rate of 40% approximately. And we're very proud of that number. We tend to use the same methodology now that we used at that time in terms of what it is that we're trying to do to affect the rate. Essentially what we're doing is we're diverting people. So we'll use the term diversion, and hence that linkage to the transitional care and diversion intervention work group. What they're doing in the medical side of things, we've been doing on the mental health side for several years now. Here is when we actually first started. I believe that we were up. There's 25 individuals at Eastern State Hospital. And by implementing the diversion strategies, community partnerships, integrated, targeted mental health care, we've been able to reduce that number significantly. As you can see, for a data person like me, you like to see downward trending slopes like that. So when there's a negative number right there, you get really excited about that. What you're trying to do is reduce things. And in this case, you can see the numbers at Eastern State went down significantly over that period of time. So this has shown how we've been increasing our capability to keep people in the community, which is really the flip side of this. So those are folks that didn't have to take the long trip over to Eastern, and they tend to stay there a long time, which is another issue. So the cost and the burden of those services on our community members can be fairly significant. So let me see if I can do this now. So some of these slides are going to be busy, hence the laser pointer. What we're looking at here would be the 2018 crisis programs. We have the Designated Crisis Responder Program, which many of you are familiar with what that is. So those are the individuals who do involuntary civil commitment evaluations. We have our diversion program, which is currently funded in part by crisis service dollars, in part by $1 million True Blood grant, and then in another part by a $100,000 Washington Association of Sheriffs and Police Chiefs grant. We've got some diverse funding sources there. And finally, we have our mobile crisis intervention team. Now, the piece of this that really is fascinating is if you think about the early warning system and what we're tracking and what is communicated in terms of involuntary treatment, admissions to Parkside, looking at a small fraction of what's happening right here in terms of the number of contacts that are being provided by the DCR. In 2018, we hospitalized 50 people. I'm sorry, 152 people. And so about 1/10, this is fairly significant, about 1/10 of the designated crisis responder interventions are actually involved in detentions. The rest of them are involved in the transitional care afterwards, or even more so, the diversion interventions that are occurring beforehand. And that, if we back up to that, that's what's happening. That huge disparity in terms of number of ITAs to the number of services provided and what they're targeting is the reason why that line goes down. So as you can see, the thing that really catches the attention of the public is these services right here. But here would be the number of hours and then the number of contacts. But behind each one of those, because we're an integrated program, we offer, when a DCR gets involved in an investigation, crisis intervention, they also communicate with the diversion team and or the mobile crisis intervention team. So if an individual is, just to give you an example, individual is at the emergency room and they're seen there and they have suicidal, persistent suicidal thoughts, and they are evaluated, DCR will then communicate to the mobile crisis intervention team. will assure follow-up and assure continuity of care. So not unlike the transitional care and diversion intervention work group in terms of what they're working on and follow-up with individuals after they're seen in the emergency department. We want to make sure that our care follows them. And in many cases, the fact that that care follows them is what gives us the confidence to send them home. If we didn't have that, we didn't have that really aggressive follow-up, and I use the word aggressive because it really is. It's like bulldogs, and we'll see a slide about that in a minute. So the mobile crisis intervention team. This is Chelan Douglas. This is just Chelan Douglas. So I know from personal experience, there's a lot of things that are happening similarly. I suspect in the Okanagan, but I can only speak to our data right now. So mobile crisis intervention, as you can see, there's 152 people that were detained. There were about 10 times that many actual activities that were occurring. And then here's the hidden part. Behind that, we had 3,300 diversion interventions, 2,600 interventions that were happening by crisis staff on follow-up. So that's just what you see in the early warning system data tends to be just really the tip of the iceberg of what's happening in order to keep people in the community. This I think I've already stated. This is the percentage of involuntary commitments that are completed by the PCRs. This little piece up here, and I'm sorry again for those people on the phone. I'm pointing at the 10% of ITA detentions and the 90% of DCR contacts in 2018. So there's a lot of activity that happens surrounding those ITA detentions. Any questions at this point?
Do you have anything like outcome data?
We're going to get to that in just a minute. So perfect, great question, thank you. The other thing, we tend to know that people are seen in the emergency room, and we're wanting to avoid that. And this is another part of that rest of the story. I do want to apologize for the busyness of this slide. I really debated as to whether or not to include it. But what you can see, what I wanted to focus on is that this little green slice of the pie, for those of you on the phone, those are the emergency department. That's really the DCRs. So when we talked about the small percentage of the work that they're actually doing that we really tend to see, that's that chunk of the pie. You can see that the diversion team's doing about 21%, and those ones are happening in the courts, they're happening in the jail, they're happening out in the field with law enforcement. There's a lot of activity. By far, the emphasis on activity in Chelan Douglas is out in the field. This other piece of the pie here breaks down into all of this stuff over here. The other 4% that you see here is really diversion team out with law enforcement on the street, co-responding with police. And then they also are providing services in the home, just out mobile, at schools, at temporary lodging, the jail, and so on and so forth. And then finally, there's a tremendous amount of service activity that's happening back at the Community Mental Health Center in terms of phone calls and walk-in follow-up activities after individuals have been seen in the emergency room. This, I just wanted to speak of those 3,651. This was just September through December of 2018 data that happened to be easily available to me. You can see that that's sort of what the breakout was. Mostly is happening in places other than the emergency room, which is really the point. During that time, well, actually, this is this year, and I'm sorry for jumping around on the data, but this is what was available to me. We built in tracking indicators into our logic system to basically measure what specific outcomes are we seeing, what are we achieving with these services, and we asked the clinicians to basically check a box and then write a narrative justifying why they checked that box. If the case was an individual seen on the street with law enforcement and they had engaged in a criminal activity, they did not wind up in the jail, they check that box. And then I go in and read the narrative and say, well, is that really an outcome of a jail diversion? And if so, yes. My understanding, we'll get to it, is that each one of those has approximately $5,000 price tag on it, although it can be much more, depending upon the nature of the crime, because that's based on about a $2,500 average jail stay, and then the adjudication process and the cost associated with the person. Very, very difficult to estimate. They didn't put that data here because it's complicated and it's time consuming. The other thing, even more significantly, is the emergency department. As far as we know, those are about $2,200 to $2,400 on average per visit. And this year we diverted 42 individuals. Our staff kept 42 people from going to the emergency room, which is, again, one of these things that we share with the Transitional Care and Diversion Intervention Work Group. It's one of the outcomes that we want to be getting at in terms of how do we prevent people using the emergency department and clogging up that facility if it's not necessary. Questions? I'm particularly proud of this slide. This is our follow-up ratio. So I explained earlier that when the DCRs or a mental health professional sees an individual at the emergency room or in any other facility and they believe that some sort of follow-up, they come up with a safety plan or they come up with a plan that allows them to send that individual home, have a mechanism by which in our clinical record we can send that to our mobile crisis team electronically. And so they can communicate that. They run reports in the morning, mobile crisis is them. And 556 cases that were referred in 2019 for follow-up, 556 of them had either direct contact or reasonable efforts in the chart showing that the mobile crisis intervention team made every effort that they could to locate, track down that individual and follow up with them, and hence provide the continuity of care that is necessary. It will help them transition out of their crisis and back into the community. That might include psychoeducational services, helping them with transportation, helping them to make appointments, reassessing the suicidality. We always do that. If there's homicidality or gravely disabled features in there, they will assess that as well. So they're doing that follow-up service, and every single time that it's been requested, we're proud to say there's evidence that they made effort to go ahead and do that.
So you saw 500 duplicated, and is that
That may be, that's probably duplicated in 2019. And by duplicated, for those who don't know what we're talking about, one individual might have multiple crises. So they were to see two different DCRs or two different mental health professionals on different occasions, and they might be referred multiple times, in which case they get multiple roles.
2019 is
January through March 31st, which just happened, and I was able to get that data, I think, over the weekend, which is why, Arlene, I was not able to get it to you sooner. So I wanted to let that first quarter be done. Okay, now, this is another really
folks that you weren't, what was the percent of folks that you could not locate despite multiple attempts in terms of?
Anecdotally, I would probably say about 20%.
20%.
Oftentimes we see them giving us a number that's not good, it's been disconnected. They weren't from our catchment area. They had a crisis that happened while they were en route from Seattle to Spokane, and they wound up in one of our emergency rooms. We just can't track them. Staff in 3 efforts, they document that, and then if they're not able to get that done, then they close the chart. Unless, of course, there's something really, really volatile about the circumstance, in which case they might do an attempt to locate through law enforcement, depending on the circumstances.
Of those you have contact with within the 7 days, how many of those engage in treatment in terms of they're getting into routine service?
That's a great question, and unfortunately, I can't answer that today.
Okay. More on that later as things evolve.
Okay.
Thank you.
We're working on our data system to be able to answer that question, though. I thank you for bringing that. So this is another really kind of unaddressed population. This is the forensic utilization. These are the number of referrals that have come out of Chelan County. And I think you're looking along the bottom here, you're looking at this would be November, December of 17, and then we go into 18 and through 19. And again, we see that negative slope. What's happening is the diversion team is working with these individuals, catching folks either in the field before they are ever arrested in the first place, or post-booking, pre-trial diversion. Our staff work with them to make sure that they do not have to go to Eastern State Hospital and use those extremely scarce resources. If those individuals that have to sit in jail awaiting that outcome, if they exceed 7 days for an evaluation, that's a $10,000 a day fine to the state. So it's a really critical mission, and that was what our True Blood grant was all about, was making sure that that doesn't happen. And we've been really thankful to see that the outcome data is supporting that they're actually having an effect on the utilization of forensic services at Eastern State Hospital. Questions? Now, all of this is fun to look at in the aggregate, but part of the question becomes what happens to a single individual and what is the outcome of a single individual? And so we've been gathering data. We started a new electronic record in January of 18, which, as it turns out, happens to have a little bit easier data reporting and data collection potential. It's more modifiable for us than Avatar was, which was our previous system. And Krista Villeneuve hired a data analyst who was able to write programs for us, and we're able to get the data back out of the system so that we can share it. This one's a little complicated and a little cluttered, so hence the pointer, and let me explain. Along this axis, you see time. So you can see here we had 2017, and then if we launch into 2018 and 19 here. So up the vertical axis, and I think my laser pointer just died, so now we're all in the same boat. I need my coffee after that. Okay, so what you see here are, you have time by the number of encounters. Within the colors are certain programs or provider activity level. So this tells a story of what happened to a single individual. This was a case of aggravated assault. The blue, as you can see, these are law enforcement and jail contacts. And in 2017, this individual had several law enforcement contacts and 2 incarcerations. And we were called in as a result of our, first our WASPIG, or Washington Association of Sheriffs and Police Chiefs, duties, law enforcement co-responding. And then we saw what was happening, and this individual was profoundly ill, major depressive disorder with psychotic features, one of the most flat affect, one of the most non-responsive emotionally that I've ever seen in my career. Amazingly, it was like just no emotion at all. And so we work with this individual. You can see what happens. The purple is substance use. The dark blue are the diversion team and the number of activities that they were involved in a given month. And then the green is our crisis program. And in some cases, it might be the same DCR working on the diversion side, switching hats and then moving over to be involved in a detention or crisis services. In other cases, it might be different. What you can see here is this individual, what the story that this tells is that this individual's in trouble, very, very ill, and then all of a sudden there's an increase in the number of contacts that are happening within certain programs. And you can kind of see this curve that happens here where they sort of scoop this individual up, where we realize this person's in trouble, needs some assistance, significantly did not belong in jail, and really didn't belong at Eastern State Hospital until we had done some things that were, we tried some things here in the community, our paradigm. So you can see those go up, and they're really, really intensive initially after we have that contact with the person. Now the red is the outpatient mental health, and the purple is the substance use disorder. The True Blood court asked us, why is this so different from this? And I'm wondering if there's anyone in the room that knows the answer to that. Substance use, we've really had a hard time getting people to connect and link to substance use. We do have our own, we've developed, Catholic Charity has a substance use program, and we're able to get people linked up with that, sometimes with the center and other providers. But we did make that happen. But you can see that the red, which is the outpatient, really established a solid connection. What they achieved in the blue part of it, the green was an involuntary treatment that was necessary to stabilize the person on an emergent basis. And then while that was happening, the blue, dark blue, was the diversion team working out a stipulated order of continuance, which means a diversion agreement saying court will suspend or dismiss these charges provided you follow through with your treatment. So it's kind of like an LRA, but it's actually done through the courts and has a little bit more teeth than an LRA because it'll be wind up in jail potentially if it's revoked. So that was the circumstance. You can see that those interventions come in initially, and then it kind of passed off and handed off to the less expensive, less intensive outpatient services. In this particular case, I think the punchline for this really is, see these blue things? Well, they disappeared. as we look across here, and that's really the compelling part of this story. Our data analyst, we wrote a program that allows us to pull these outcomes together on each individual that we serve, and we can sit around and pull these charts all day long. I actually had a slide, but I had to hand draw some things on it, and my boss said, that looks kind of cheesy, don't put it in there for this group. So I put it out. But there were a whole bunch of them, and this is something that is replicable. And I think we've demonstrated that we can achieve these outcomes over and over again. It's kind of a nice story, and it's a story of how our services affect one individual person. Are there any questions on this? Because this is really a complicated slide.
Let me see if I can summarize this. Lots of contacts with law enforcement, lots of contacts hitting the ED, diversion intervenes, and then that goes away. And now they're in outpatient services and they're not hitting any more law enforcement resources.
So we replace this with this, which I think is really ultimately what we want to do.
Good work.
Okay. Yes. Well, you pointed me in that direction, so thank you. All right. Now, in a similar case that had a similar outcome, but this is in our diversion intervention case notes, we keep track of what kind of service, what domain of life were we addressing. So this is a single case study again, and you can see if we were going to fund things under diversion, which we do under TrueBlood, what would we want to throw our money at? What kind of services are necessary? Where are we going to, if we had to buy services like 4, as you can see, well, they're using transportation. They can't, services don't work if they can't get to where they need to be. They need housing, and we pay for that when we can find it and when we can get them approved for it. Mental health services and food and clothing are the things that those are really the big service needs or service domains that we're using. So this case actually was another one that this individual cut wrists very, very badly, had to be hospitalized, detained, again, stipulated order of continuance, and was successful with no further law enforcement contacts. Questions? I know I'm on a timeline, so I'm going to hurry up a little bit to make sure I meet it. This is the aggregate, same slide that you just saw, but in aggregate for March 1st through November 30th of 2018, showing the total numbers just for the diversion team in terms of where were they putting their efforts when we were case managing. I think we brought this up at one of the other committee groups on community, law enforcement, and care. You can see, obviously, our bias is mental health. We want to get people linked up. So there were 630 times, not a distinct count. This would have been the same, repeated over and over if necessary for an individual. And then housing was next with transportation, and then a variety of other linkages. We have Catholic Charities has opened up an integrated medical clinic, and so there's been an increased emphasis on the psych and med management as well as some of the medical and healthcare needs, providing a lot of those services. This is what's necessary, we have learned, in order to be able to get a person functioning stably in the community. If we don't have all of these and we're just focusing on this or this, then well, they're not getting where they need to be, and they're not in a safe and stable place where they can actually benefit from treatment. So part of the benefit from TrueBlood is that the people actually, our retention rates are ridiculous. If they're in our transitions programs, like 87% stay in the program because they get something out of it. It's you know, ecologically valid, I think is the term. It makes sense to them. So that's kind of a MRI, I guess, if you will, of case management services that are happening in the community. Questions on any of that?
Between the mental health and the substance use disorders, oftentimes people have co-occurring. Are individuals duplicated in those two columns, or are those discrete individuals that were sort of selected based on most significant diagnosis?
I understood the question. I think it's both. Have individuals who have co-occurring disorders. We really have a hard time. If we can't make people engage in substance use services, one of the issues there is marijuana is legal. And sometimes it's causing big problems in their life, the use is, but it makes the whole system is sort of falling all over itself about that. right now in terms of what to do, including the law enforcement and the courts. It's kind of hard to know what we need to do when that's the case. Other situations are clearer, but does that answer your question?
Yeah, that helps on that one. And the psych med management, does the med management include med management for individuals who have substance use disorders? So buprenorphine or meds for folks who have alcohol use disorder, whatever the case would be? Or is it strictly psychotropics for mental health conditions?
I can answer that.
Yes.
This is Marty. So,
Susan, can
yes.
you step to a microphone, please? Oh. And turn it off.
So the answer is yes, and so we are doing substance use disorders, but we have not started buprenorphine yet. So we do some. Our PCP in the integrated clinic is starting to do buprenorphine now, and as well as some other substance use medical treatment processes for those folks. So it's sort of just coming to pass, but the medical, the psychiatric providers have been doing some of that, just not buprenorphine yet. Okay, thank you.
All right, thank you. And I think, this was, I promised you estimates on our dollar savings from various diversions, and we're looking at about 102 this year, 102,000, 103,000 on emergency department diversions, 45,000. We also have a hospital diversion category, but I'm not confident that data is really what I want it to be. But if so, the hospitalizations are incredibly expensive. I don't want to start throwing around really, really huge numbers until I knew that they're really valid. These ones we know this is pretty reasonable and realistic. The hospital diversion, to the extent that those are actually valid, is a huge number. Nothing dwarfing the scale of these. So before I throw that out there, I want to vet it a little bit more carefully. That, I believe, is it. That's the story, kind of the rest of the story, if you will. I appreciate the opportunity to be able to tell it, because our system doesn't often give an opportunity to be able to talk about some of these things where we have to get down in the weeds. So with that, are there any other comments or questions?
I just have a quick question. It was my understanding with the start of this True Blood team that the intent was to go regional to start in the Chelan area. Can you update me on that?
Our intention is to go regional. We were funded for Chelan Douglas, and to the extent we have had a few interactions with individuals up in the Okanagan County Jail, by the way. We try to work and coordinate with the OBHC and the jail staff whenever that is happening, but those individuals typically live in East Wenatchee, and so they're in our catchment area. And East Wenatchee sends its people who are incarcerated up to Okanagan.
So there's no formal plan at this point to expand specifically to Okanagan or Grant County?
Can you address that?
Not yet. We have to work with the courts on it. We're currently we're finishing the last of an 18-month grant, and then expansion dollars come up in the next year. So
we've experimented with some cases.
Yeah, I was curious.
Yeah, okay. We've experimented with some cases whenever we can. If we can provide services, our preference is to do so. So, any other questions, comments, concerns?
Just a last comment. The goal with the data is that the more we can get data out there, we can identify where the barriers are in treatment services and gaps, and that having things like this gives us that opportunity to really look at what's going on across the region, and hopefully have that opportunity to really create some transparency and talk about data at a regional level so that we're able to identify where gaps are.
Chris, thanks, Eric.
Next up we have Deb from Action Health Partners, who's going to talk to us a little bit about Pathways Hub. We had decided that we were going to bring each of the work groups, whether it be the opioids, TCDI, Pathways Hub, or CHIES, in every meeting, so they would talk to you guys about once a quarter, so we can really tie what's happening with the WPCC to what other things are happening with the NCECH. So today we have Action Health Partners and Pathways Hub.
Thank you.
So today I'm just going to talk really high level about the Pathways Hub and the highlights to date, challenges, and next steps. I'm actually most excited about next steps because this is definitely the group that we need to connect with. So for those of you who saw my nesting bowl demonstration last year at the summit, this is a way to show our care coordination network. So if the largest bowl at the ACH Summit was the ACH, in this particular case, the largest bowl is our Care Coordination Network Hub. And the programs that we have within the Network Hub are both the Pathways and the Health Homes program, which are both community care coordination programs. Yellow represents our contracted network. So both of those programs we contract with community agencies that employ the boots on the ground. The next bowl talks about the boots on the ground and the services that they deliver, which is around the social determinants. And I loved Eric's slide that actually really aligns with the identified pathways that seem to be predominant in the Pathways Hub. So, and then to me, the green bowl is wellness. And in my world, wellness is not balanced if we don't have physical, mental, social, spiritual, financial, and environmental wellness all in place. And we know that the social determinant partners are who help ensure that that wellness is balanced. And the small bowl in the middle is the whole person that every single one of us are taken care of. So here's a schematic. I try, every time I present this, I try to draw it in a different way so it starts connecting with folks. But here's an example, or this is a schematic that talks about how agencies can be involved with the hub. We have referral partners. We have community specialist services agencies. The acronym that's easier to say is CSSA. And we have the community services partners, those social determinant partners that have what the clients need. So referral partners actually identify the target population and refer to us, and they're referring into the Pathways program. We assign those clients out to the agencies that we're contracted with. Those supervisors in turn assign them out to the different Pathways community specialists that they have, and the Pathways community specialist role is connecting to the social service partners. It is possible for a single agency to be partnered with us under all three categories. It can be a referral partner, as well as a CSSA, and every single person in this room is already a community services partner because you are either physical health care providers that the Pathways community specialists are ensuring that the clients are getting to the appointments or getting set up in the medical home or behavioral health as well. So you can be a combination of anything. In a perfect world, I would love to see all of our well, not in a perfect world, sorry. Some of the primary care providers are both referral and CSSA. And that's, I think, the perfect combination to fill up those caseloads because you already have relationships with the individuals. So if you are acting as a referral partner and you identify them, you can refer them to us and we would turn around and just assign them back to you so you can fill your caseloads. So then the clients actually, the patients actually know the service, who's delivering the services. But what we do find there is also a need for community-based organizations to also be a CSSA. So my perfect world in my network, I would have primary care providers in each county that are CSSAs. I would have behavioral health who are CSSAs, and I would have at least one community-based organization as well that acts as a CSSA. So this slide just puts the current partners' names into the appropriate dots. Bless you. So we have Moses Lake Community Health and Rural Resources, and next week is the final training for Grant Integrated. I got to get your circle in there and get Roger in there, right? Yes. So by the end of next week, Roger will be able to start receiving referrals, and we will have 4 Pathways Community Specialists in Grant County. So here's some data to date. We've got 187 adult clients assigned across the agencies, and 33 of them are enrolled. So that puts us at about an 18% enrollment percentage. The due diligence lists are just exactly like Eric was talking about. There's a lot of folks that we don't have current contact information. It's hard to find these folks. They're either experiencing homelessness and they're back behind Walmart in Moses Lake, or they've given wrong contact information, or we did find a challenge with the Eddie, and the information that we were getting from Eddie pre-managed, it was old phone numbers. So we're trying to get past that and trying to be able to get more current contact information. There's a few pediatric clients, a little bit of a challenge with pediatric clients because of the behavioral health and foster care and all the different HIPAA. It's actually our agencies that are challenged to work with the children. So I'm hoping getting the behavioral health agency on board that's used to working around those rules.
In the past, about when the child came in through referral through 3 visits in the ER, did you decide on whether the patient or the parent was going to be enrollee or whether the child was going to be the enroller?
It's got to be the child that's the enrollee, but it's logical that we're working with the parent and not the child. Yeah. So unless the parent, for the current funding, this is where we get really complicated. For the current funding, the parent would also have to have 3 ER visits for us to be able to pay for those pathways. I guess that might be a possibility, but in the future, as we get more graded funding into the hub, and we can look at that for enrolling the parent. Because the reality is, it's the parent that deals with the housing for the child, not the child. It's outside of the child's control. The pathways, as you can see over on the right-hand side, the pathways risk scorecard are just, the blue shows the total pathways that are initiated. The gray shows the pathways that are completed. So it's encouraging to see as we're moving forward that we're getting more and more completed pathways. And then the orange are the pathways that are finished incomplete, which means there probably wasn't a resource available for that pathway to actually close, so we just close it incomplete. In my mind, in time, that's going to start showing our community gaps. And then the top 5 pathways initiated there on the bottom left for the history of the program. Social services is the most, medical referral second, education, tobacco cessation, housing, and then on down the line. So this next slide, we actually pull out the social service there. We detail the social service, and utilities assistance, we have to take into consideration that this was wintertime, October through February, so there's a lot of folks probably asking. I'm assuming utilities assistance will go down once the weather gets better. But again, I find this interesting that transportation aligned with the Catholic Charities findings in the True Blood as well. The top right just shows what the different types of medical pathways that have been opened are. And the education down at the bottom talks about it's either healthy living. I honestly don't know what the other and the dash are. We're going to have to dig in a little bit to find out what those are, and probably actually start defining those a little bit better. This is just the system, the IT system right out of the box. Lisa, did you have a question?
I was just curious what the other is on the front right.
Yeah, I haven't asked my staff to dig into that. I'm not positive what that other is, but we can dig. My guess is we'd have to go into the notes of those to find out what the notes are. So our challenges to date, I think there's two that we constantly talk about at the Pathways Hub Advisory Board. One of them is simply finding the clients. This is no different than the startup for the Health Home Program when it started in 2014, 13, 14. These are transient folks, and they're difficult to find. We're trying all kinds of different solutions. We do have access now to most of the medical records, like front face sheets in Epic for sure, and I don't know that we do for Samaritan, to look at more current contact information and try to update that. The client management system is the IT platform, is very sophisticated. And it's very difficult. You know, there are lots of boxes to check, and don't forget on this person, it's this box. It's complicated, and training, we're constantly going back and training the Pathways community specialists. We're still working on defining workflows. The current referral partner, we still are not electronic with them. Electronic referral is going to be so much easier for us, because if it's not electronic referral, it means I have an individual staff doing data entry, and I don't have that many staff. So as we move forward and engage referral partners, the electronic is the way to do it, so we can bidirectionally communicate. And then the third challenge as a hub is the Pathways Community Specialist training. There was a hiccup right out of the gate in our state for the training, and the group has had to regroup, and the cost for training is currently very cost prohibitive. So we are working really closely. We have monthly meetings with the other 5 hubs in the state, looking at how do we strategize and how do we create a statewide training. And in the meantime, just because the training is not available does not mean we can't scale up. The community health worker training, the DOH community health worker training, or any peer specialist training is a good enough baseline. If anybody has that, we can actually hire them and get them, or the CSSAs could hire folks that have that experience or that training and get them started. Some of the other, like mental health first aid, motivational interviewing, the specific training on the platform that we would do anyhow, those kinds of things we can pick up once the folks are on board. So while it sometimes feels like a barrier to me that I would like to have a training to say, here's the date of the training, go get the training, like we've done with our others so far, that's not available to us at this time. So we're ready to increase our program reach, because my logic is we just simply need more referrals so we can fill up our caseloads. The more referrals we have, the more in people that would be engaged and fill up the caseloads. So I worked with Caroline and Crystal, and Caroline was able to get some data from King County, is that correct? Yeah, Public Health, through the all payer claims database on ED utilization. The next slide I'll show you here shows some numbers. So we actually have numbers, and our experience in the Health Home program, we know that this program is very expensive to deliver because of the driving to the clients, right? This is a program that is on the ground in the community going to the clients. So I created zones based on number of potentially eligible folks from the all payers claim database, and kept it at a 50-mile radius from where the Pathways Community Specialist starts. And within that 50-mile radius, we can cost contain the transportation. What we found with our agencies in the Health Home program, if they try to have the care coordinators in the urban centers and drive to all of the rural areas, it's not cost effective to have them do that much driving. So here's my grid that I created to actually start zoning and scaling. Grant A is where we currently are. Moses Lake is in Grant A. So as soon as we can help the referral partners expand their EDI list to include these zip codes so they're alerted when these folks are in the ED, we can start receiving referrals from all of those different zip codes. My sense is, based on the numbers, logically we will go to Chelan Douglas A next, which is what we were on target for, but I'm also looking at Grant B, which would pull in up at Cooley Dam, because some of our utilization maps that Healthcare Authority produced actually shows a lot of the utilization going north. And just based on, I know there was some concern about would there be enough engagement to fill caseloads. And so what you see over there or across the top are, if it's a 10% engagement rate, how many people would that be all the way up to 50%? And certainly our goal would be higher than 50%. Our health home CCO network engagement is about 28% right now, and we anticipate it being above 30. It has to be above 30 to get the shared savings starting July 1st. So I think there's plenty of eligible clients, definitely, to fill the caseloads. We just have to cast our net wider. So just increasing with our referral partners and connecting with the primary care is what we really have to do next. There's a lot of crossover with the TCBI partners. I see an opportunity for EMS to actually be a referral partner as well, and then other community-based organizations. So on this list are different ways I've suggested that you guys can reach out to us. We're happy to reach out to you too, but we're a small and nimble staff, so we need the nudges too, because we get caught in the weeds of the day-to-day work. And I've been given my 2-minute warning, so. Sorry, I'm going too far. There we go. Any last minute questions, or I'm happy to answer questions between meetings too, if anybody has any.
What is your volume to date compared to what you anticipated the volume to be?
Engagement is much lower. Yeah. The numbers are there, the engagement is just low.
What would you hope it would be? What would be the goal based on what you would think was typical, given the current folks you've had contact with?
Well, we've had like 340 some referrals from just the 98837 zip code. So if we went back to this slide, actually the number of referrals coming in is probably pretty equivalent, considering that there's 1390 total, right? And 300 and some. Now some of those may be duplicates, I don't know.
Is that low engagement?
Sorry, is that low engagement typical of the other hubs or unique to this area? Do you have any sense of that?
Well, we were the first, the other hubs have just barely launched in the last month or so, so it's hard to compare. And Pierce would be the only other hub that's been up and running long enough, but their volume, their referrals are huge because of the urban center. So I don't know that it's fair to compare.
Target population.
And a different target population. That's the other thing too, is all of our target populations are different.
Right, understand.
Any other questions for Deb? So,
Gosh, I keep doing that.
I just want to remind you guys that we had sent out the guideway to Pathways Community Hub when you guys were working on your change plans to help you to see where you as a WPCC partner fall. And there were a few things that you could do about if it's not in your region. Sorry, this is on page 3 of 3. Sorry, packet's not numbered. It's towards the back. It's after the slide deck. But understand how the Pathway Hubs works. There is a self-paced training developed by Action Health Partners. It's on your website, is that correct? They hold community meetings, and if you want a scheduled presentation, you can contact Deb and she will come and present to you and your staff. And then once it gets to your region, you can start to form those formal linkages and referrals So if you have any other questions with that, feel free to contact Deb or me. Anything right now? Okay, we are a little behind schedule. I apologize, Roger, but I will turn it over to you, and I'm sure you'll catch us up.
We'll catch up. Again, I'm Roger Sharpney. I'm part of the CCMI CSI consulting team. That's Milliman.
Roger, sorry, can you please turn your mic on?
Again, Roger Sharpney, part of the consulting team supporting this effort. A very tough act to follow on those two presentations. You know, when you look at the amount of work that's going on here as part of this accountable community, all of you are working on your individual change plans and your quality improvement efforts. So there's a tremendous amount of just organic work going on in improving quality. And then you look at the shared work that you're doing. Diversions that we just saw, what the impact can be on the people you're serving, and what the Pathway Hub can do in terms of leveraging resources. It's really, really extraordinary to think about it. Our role as consultants is to help you build capacity and accelerate your execution strategies. And so as part of what we've been doing is a series of leadership modules over time, just reminding all of us as leaders, those that are supporting the organization, part of our roles and things to be thinking about. And today I'm going to talk about sustainability. If you're thinking about all the capacity building going on, whether it's motivational interviewing, empanelment, diversions, all the other activities, the Pathway Hub, whatever it is, all of that work has to be able to be sustained. I've working with a group in the Midwest that implemented a 340B pharmacy program. And it's a very powerful program to help people on Medicaid get discounted drugs. Many of you have 340B, some of you do. And this organization went out and did all of the classic things to engage their providers and staff to participate and give patients access to this. They have the pharmacies on site to send the people. And they are having a 70% leakage of patients leaving the property and going elsewhere to get their drugs at higher expense. It's $75 million to this system. In terms of the lost revenue by not capturing those patients. And all of it is lack of building the reliable systems in their organization to get people to connect them to their own pharmacy on site in their own clinic. And so that's what this is really all about. Why are we so challenged in making things stick? I just recently implemented a change in a project management software in my own company. And it's been up and running for probably 7 or 8 months. And I had one of my managers coming and saying, we got to get rid of it. It's not working. You know, it's just too much of a burden, blah, blah, blah. And as we got to go into it, immediately saw some of the failures in the reliability that we had not built in. So this is stuff that is somewhat common sense. But as Mark Twain said, common sense is that sense rarely commonly applied. All right, so this is a reminder for those of you that have really strong systems to ensure the scalability and reliability. I ask you to jump in and help with this. So this is a light slide that's a little bit tough to read by Edgar Dale. But the intent of this, and this is somewhat of an old slide, and more recently people are challenging the data here. But what it suggested is that when you hear something, you retain about 10% of it 2 weeks later. And as you move down the scale of when you read, 10%, if you hear it, 20%, if you're looking at pictures, a graphical image, it's about 30% retention rate, and all the way down to where if you say it and do it, you have a much higher retention rate. About 90%, 2 weeks later, you remember. So for those of you that have participated in any of the lands or the sprints, at the end of each module, we ask for some activity to go back in the field to apply the concepts that were taught in the session so that you're actually doing. And that moves you farther into that retention stage and less than if we send things out. Now in organizations, we do town hall meetings, we send out emails, we send out memos, we send information out and say, go do it. And that's why we have 70% leakage in our pharmacy return rate. We don't get it down to how do we get people to actually adopt what we're trying to change. So there's some sustainability principles. If we're making a change, making sure that the new workflow, what we're expecting people to do is crystal clear. That we have that mapped out so people can really understand.
Secondly, we have to answer the question, or what are the roles of each of the people in the flow? Are they very clear on what their role is in the handoff, when and how that has to take place? Do we have clear policies that are going to lead to the sustainability of whatever change that we're making? Whether it's the 340B or the pathway hubs or whatever it is, this is the pathway, this is what we want you to do, this is our policy to support it. Are the training systems in place to help scale it? What's the training packet to go to each clinic, to go to each provider team, to go to each piece on how to make sure that that sustains? Do we have the reinforcement to constantly bring that in? How is it tied into our management meetings? How is it tied into our town hall? The communication systems, what we publish in our newspapers, what we publish on our bulletin boards, all of the reinforcement systems that make this the new way of doing things. Do we have measures of performance and reliability of the system over time? Is there someone responsible for seeing this thing through and owning it long term? What we tend to do is start a project, take it to a certain point, send out the emails, and they go, boy, that worked, what a victory. And then 9 months later, we're coming back with someone saying, this thing isn't working, we got to start all over again. So who owns it? Who is established as the owner of that process and can track it? And then how are we doing the audits periodically to make sure that it's working? What's that quality assurance, quality control function to see that it's actually doing what it's supposed to be doing? For those of you that are in environments with strong accreditation, Joint Commission and some of the other accrediting bodies, they're really high in reliability principles, building in these concepts of reliability theory. There's a series of techniques and tools around reliability, some of them just previously mentioned, but really having standardized processes in place, using reminders that are very conspicuous, contiguous, contextual, that are quick reminders that get people's attention, making the desired action a default. I had an organization I worked with that put in a new form on a floor. They wanted to keep the old form in place for a while, just so that in case some people were having some trouble with it. Guaranteed prescription for failure. You have to make that the new way, not an option of keeping the old way as a way to go. Where possible, replacing opt-in with opt-out. If you have to have a voluntary action to get in, it's much more difficult to get the masses to do that. If they're all included, much easier than the other pathway. Obviously, reducing the complexity. A lot of times you roll out programs and they're so complex, the information we're sending is just overwhelming, people just turn it off. So trying to reduce the complexity as much as possible. Making failure difficult and smoothing the workflow. An example of another concept of forcing functions. Make it the way that has to be done. Make it difficult to fail. Many of you have experienced the change in ATM machines. In the old days, you go to an ATM machine, you put your card in, and then money would come out, and then most people would walk away and leave their card in the machine. And so they now have reversed the flow. So in order to get your money, you have to take your card out, and then the money comes out of the machine. So that's a forcing function. It forces you to go into that pathway. So be thinking from a design perspective, how can we create it so that's the natural pathway for people to be able to do their work? And then promoting clear communication. So here's an example of some of the tools. This is an example of a top half of a policy, but as you see the bottom half of the policy, it starts to spell out a little bit more visually and by category. Here are the roles of people in that policy. So we have these policy and procedure manuals that are 11 to 13 volumes out there for our staff, and they're like, oh my, who's going to read all that, right? But if you can have a very quick cheat sheet that explains specifically what are the roles, when, and how people are supposed to do it, then much higher compliance. And then this organization took it a step further and developed the process flow that is very visual. And these process flows are what are posted on the walls and in the work units. So if you have a new employee coming in, go read the policy manual over there. It's look at the wall right there. This is the flow for this particular piece. So you can see right away what the pathway is. And this is a group in Colorado that developed what's called a swim lane diagram, for those that haven't seen something like this, where each of the roles are spelled out. On the top, they have the core measures that they're tracking for this diabetes care. On the left-hand side are the individual roles. And then they have the actions that need to be taken by each member of the staff for that kind of flow. So those kind of tools help build the reliability. It helped build the opportunity for it to be reinforced in the environment. Use of visual controls, this, again, a lot of shadow boards, labeling bins, making things very crystal clear in terms of the new workflow, so that there's no opportunity, no confusion in the process. And there's some examples of starting to see increased tools being visual on the wall. Some of these are data tools providing feedback. Some of them are workflows that are explaining how to do things. Some of them are the color charts showing the pathway. And increasingly, these are moving to electronic formats. Starting to see much more often electronic boards in organizations where you can constantly be updating and changing those visual controls and tools and embedding them. There's actually a company called DIRT that makes modular walls and construction, and they've now embedded in their walls this kind of technology so that you can be constantly updating and communicating and doing visual controls in the workroom, in the exam room, or wherever it may be. So let me just stop there and see about comments or questions or any examples from others on how to ensure some of this sustainability of and reliability of new changes that you're making. Any questions or any examples?
Implemented a monthly QI/QA meeting that follows up with PDSAs on our intake process, our nurse case management, and we're using that on a monthly basis to review the progress, and that's been really helpful.
So Chris is talking about a monthly meeting where they review the different changes, PDSA cycles, and then they talk about many of these things in terms of how do we ensure that they're happening. We're reviewing the data, make sure that it's following on. Yeah. Was that Sheila I heard on the phone?
Yeah, it was. Roger, can you go back to that slide that showed the process of learning?
The methodology, yep, the cone of learning, yes.
Okay, so talk me through that just a little bit more, because I want to use this leadership in our clinic, because we do so much of the sharing one time and hoping for sustained change. So just go over this a little bit.
Sure. This is a body of work that comes from adult learning theory. How do we learn as adults? And a lot of work going on now, since so much learning is through the web. It's changing our learning habits and the way we absorb and process information. But this basically walks through from the very top. You'll see on the right-hand side, there's passive learning and then there's active learning. And passive learning starts with reading. So if you look 2 weeks out, you retain about 10% of what you read. If you hear the words, about 20%, and if you see it, about 30%. I've had several children with learning disabilities, and one of my children, one of my sons, has to write out in class when he was hearing. They had to actually write continuously, and if you wrote it, he retained it. If he didn't read it, he had an auditory processing and couldn't absorb it. I have another son, interestingly enough, who we think has a photographic memory. And the other day, he was studying for a real estate test. And I saw him, and he was reading, highlighting it, and then writing it down, and then he said it out loud. And as I was preparing for this thing, oh my gosh, this is exactly the adult learning theory. He's actually translating it into the ways that he can retain. And here I thought he had a photographic memory, but it's these basic process. 50% is when you see something, so this is why we like visual controls, those kind of reminders. 70% of hearing, and then 90% of 70% when you say, and then 90% is when we actually say something and then do it. So this is the teach-back model in clinical medicine and in other environments. If you tell something to a patient and then they walk away saying, I don't remember what the doctor said, but if you ask the patient, okay, what's your plan? Can you repeat what we said here, and what are you going to do about it? Then the patient suddenly goes, can you remind me, or let's talk about it again. And then they, okay, tell me what you're going to do, and that way they retain the concepts. Does that help, Sheila?
Yeah, it really is. It just helps with that concept. Or what I continue to hear is, well, I told them.
And this is all a function. We are all so busy. There's so many competing priorities hitting us, so it forces us to get sloppy and not get disciplined in terms of thinking about things and packaging the right things as we move on.
Audrey, can I say? This is another reason why we have homework on learning activities, so that you can actually do what was being taught.
Exactly. Any other questions or comments or other examples? Yes, ma'am.
That turnover effect on sustainability is huge.
Absolutely. So if you're having somewhere between 12 and 30% turnover, depending on the organizations, in the long-term care industry, it's up to 70% turnover of staff in some of the facilities. If you have that, if you don't have those kind of visual controls and systems in place, you are just building in poor quality. There just isn't the time to train and do everything you need to do. So really paying attention to those core principles is critical in a high turnover environment.
I might add, sometimes it's helpful if you're doing a dramatic change, moving from one system to another. Sometimes having an event where you sort of like have almost like a funeral or something for the old system, but it really kind of something that really marks the changeover, I found is a pretty good way to kind of push people to doing something different and accept it. So kind of have that ending zone.
Great observation.
Missed our chance for Avatar.
Mr. Chen, for Avatar. All right, with that, let's transition. And what we wanted to do is talk forward now in terms of the work ahead. I think it was David Olson at the last meeting said, where did some of these things that we're working on come from? Some of the topics and how are we going about this? Just to create a break and trail back, it was about a year ago that we were all together and had a full day planning session. And at that planning session, you brainstormed a list of topics and core competencies that you wanted to work on. Those core competencies were the basis of the work we've been doing up until now. So integration of behavioral health into primary care, primary care into behavioral health were some of the top areas that you talked about last year. Motivational interviewing was other topics, and basics and quality improvement training. So that has all been acting out up until this time. We had several learning and action networks, one on helping you all develop your change plans. You're now implementing your change plans, and you're about to do a second cycle of reporting on your change plan. So that's now going to give us
done by now, you're in trouble.
Yeah. So you're. So we're now going to have some data to start to see 2 data points of what's happening in the environment. What are you working on, and where's the effort and energy going? So we've been trying to plan over the next 6 months to a year. Where can we be most helpful to you? What are your greatest priorities? And we've talked over the last couple of months about some of the data, looked at some of the state data. We've talked about asthma, whether it was a high priority, not a high priority. Had some discussions about other topics, and then we just most recently did a survey. So with the survey, we wanted to present the results back to you of what we heard. And so if you look at one of the first issues was to please rank potential topics for learning activities in order of priority for your organization. And you'll see optimizing care teams was the highest priority. That came back just in terms of frequency distribution. So left-hand column, the y-axis, or the number of respondents that rank that. And so access and behavioral health, population health, we're second. And then you see access is a close third in terms of third or fourth in terms of topics. So this is just a first cut of what you relayed are some of the most important things to you. And certainly this is informing how we see and would recommend things moving forward. There are a lot of other topics that were suggested. Gathering data through conversations and how to encourage patient storytelling was a topic. Data extraction for measurement and reporting. Integrating treatment plans to include both behavioral and physical health, and teaching behavioral health clinicians how to address physical health coaching. Successful outreach techniques and strategies. Billing, coding, and reimbursement for critical access hospitals, RHC facilities. Generating revenue, denials management, prior authorizations. So those are some other topics. Many of these might lend themselves to one-of events, a webcast, or a short 1 or 2 webcast series. For example, coding, that might be something that could be done in a couple of sessions. So we're going to be exploring some of those one-of opportunities to help meet some of these needs. Please rank the following content areas in order of priority for your organization. So this is where we had that wonderful asthma debate going back and forth, and what are the data and how much of a priority is it? So what we heard was actually diabetes and depression were your two top priorities. So if you're going to work on clinical conditions, those would be the highest yield across the environment, the greatest opportunities for collaboration, if you would, in the environment. Other conditions, lots of other conditions, preemie care, failure to thrive, and autism evaluations, chemical dependency, lack of mental health resources in our area. Outside the obvious mental health conditions, interested in obesity as it relates to a variety of physical health conditions, trauma, COPD, colorectal cancer screening, obesity, dementia, heart failure, and sepsis. Again, some of these might be able to be dealt with in individual topic series for those interested. May not need a formal learning event, if you will. So we'll be exploring how to meet some of these needs through that mechanism. So one of the questions is how to best convene people. We are very cognizant of the amount of time it takes for people to travel, for people to participate, and to balance between face-to-face and virtual opportunities. A lot of the face-to-face opportunity moves you down also in that scale in terms of engaging others in that dialogue and acting rather than just watching a television show on the screen. So that balancing act. So we wanted to find out what's your appetite. And so what we heard is basically a high degree of interest and support on the face-to-face meetings that they, with peer organizations, we would find the benefit. Obviously, there are caveats. They have to be value-added and substantive. We don't want to just get together for the sake of getting together. But face-to-face is a valued activity. We talked about some of the requirements, and there's an annual face-to-face meetings and virtual meetings or an expectation of the WPCC. Would you be willing to attend more face-to-face meetings in a year? So this is helping us calibrate. Would we have the ability to get together more often to do some substantive learning? And what we heard is yes, people would be willing, with the caveat that again the right topics and it's value added. And we would be willing to send more people than just having one person attend. That would benefit our organization. How many team members would you be willing to send? And so we got some data back saying it depends on the topic and what the issues are, but we would be willing to send, again, more people. So translating all of this into work planning, the planning is ongoing, and so we wanted to test an idea with you, and then we'll continue to refine and come back. We'd like to pause any final design decisions until you all get the data back and see where your priorities are and what you're working on and how things are going with your own change plans. But clearly working on team-based care and how to optimize that care team is a hot topic that we've heard, and we'd like to launch a LAN in the near term addressing that specific issue. And that has the opportunity to potentially transcend both behavioral health and the primary care and other care environments. So that is something that we are in the planning stage, and we'll be looking to launch that potentially in the near future. Again, none of this is final. We're asking for you to design this, not just drop it on you. But what we would like to suggest is a model where we could broaden the learning experience, but reduce what we proposed last month in terms of the number of tracks and specific work groups or sprints or other activities that you would be asked to participate in. And what the basic model would propose is that we would have a learning session, a face-to-face learning session that would be held more likely in the fall, that would be addressing at a very high level population health, and then many of the things that you identified as those priorities. That would include some of the access pieces of it, some of the care team component pieces, and some of the chronic disease management pieces of it. And in that would be face-to-face. The model would be combining both plenary and then individual breakout opportunities on focused areas that would hopefully resonate based on the feedback that you've been provided. So we would come back with a design on this. And then work over the course of the year with a virtual learning session later in the year, in the December timeframe. This would be a half day, afternoon, morning type of format. Again, on very focused, specific topics with the potential of breakouts within that learning session. And then in 2020, to have another learning session in the first quarter. And this basically follows a quarterly pacing, if you will. Then a virtual learning session, and then another face-to-face later next summer. What the commitment would be is that we would be asking you to have a care team participate in the learning opportunity. And so this would be what you would identify as the core group that is taking care of a panel of patients that would be able to benefit from the learning and could be the prototype of your organization to be able to take that and be the champions to help spread the learning through your organizations. What we'd be asking is a monthly all-team call in between these quarterly sessions, and these quarterly gatherings, as we talked about it, and then care teams working on a common set of measures based on those high priority tracks, depression, diabetes, if those are the ones that ultimately end up in the activity. Where possible, we would want this to align with your already existing quality improvement efforts. So if you're already having projects based on something you're doing for external accredited bodies or for your internal purposes, that this aligns and that this is all part of an aligned improvement effort. So that's the broad concept. It backs off on a lot of weekly pacing and other activities, moves it to a monthly cycle. The organizations, you would be moving at your own pace, working, but you would be benefiting from the broader subject matter experts. We would be bringing, based on the topics, external subject matter experts from the region and from your organizations, and then nationally, depending upon the topic and what we would be working on. This would be augmented in the background with the practice coaches that are working with your organizations and your own internal quality improvement efforts to accelerate your work. All of this hopefully tied to the core measures that are in your change plan lands and that what you're tracking to the HCA, so that you're helping to move those needles. And then we would use this body to continue to self-adjust the learning model over the course of the year. So you would be providing feedback from your teams and helping to provide input to the design as it rolls out and we move forward. So that's the concept of where we are now. It is not a baked cake. It's a lot of ingredients with concepts that we're trying to calibrate whether this is in the right track. And if so, what we'd hope to do is at the May meeting, review the data from your input into the system and talk about that in that context. And then, so what? If this is where you are with your data, then how can we help you accelerate your work moving forward? The individual learning opportunities, quality, motivational interviewing, those things will continue based on your demand need. So if you have that need, we'll continue to be offering those. And again, the question about turnover, I think, is relative in that context. So questions and comments. Wendy, did I miss anything? Or anybody else on the phone that would like to comment or ask a question?
The only thing I want to mention is we did hear you in the survey is that you cannot participate in more than one learning activity at a time. We had proposed it, and we did hear loud and clear that one learning activity at a time.
So this would be one learning activity of which you would choose what you want to really focus on within that learning opportunity, but you're going to be benefiting from the content in the broader sense. Comments? Chris over here has got a thumb up.
I think it sounds like a great plan from the Moses Lake perspective, timely for what we're trying to work on.
It's got 3, 4 thumbs up. So enough positive feedback that we could kind of gauge here. I'm going to use some motivational interviewing techniques here. So enough that we can proceed with the planning then and come back to you with a little bit more baked and the depth in terms of what the content and approach would be. Is that You would welcome that potentially the next meeting? Okay, so that's what we'll do.
I will say that we are trying to plan that first face-to-face to coincide with the symposium that we had already planned for the year. So we're not asking for an additional one. That maybe it will be that the symposium will be the kickoff to this whole thing. And so we're working together to see how we can do it and leverage the time we have already in the MOUs so that we can be respectful of your time as well.
So trying to align this with the commitments that you already have in place and not add, and try to add as much value in terms of the topics that you're telling us that you want to work on.
This is Shoshana Palmatier from Cooley Medical Center. I have a quick comment on this. This sounds like an awesome learning activity, and we really like to participate. I think the main thing that we would appreciate is maybe just some input on dates of the meetings, especially if for provider care teams, just to make sure that they're available.
And we'd like to be able to map this out for a year so that you know ahead of time what the expectations are and you aren't scrambling to work on that. Thank you for that feedback. Any other comments or questions? All right, Wendy, I'll turn it back over.
Thanks, Roger.
Thanks, Roger. I look forward to really getting this kicked off so we're not keep coming back to you. Just so you know, we did present that learning activity schedule back in December. This is not necessarily replacing that. We're just organizing the pieces in a better way so that it better meets your needs. So the content is basically the same. The way we talked about it once is the way we originally presented it. The puzzle pieces were laid out on the table, and now we're putting the puzzle together. So it's basically the same thing if you look at the content. We are getting to some content specific, topic specific. But the general thread is we're not switching course. We're just adapting it based on the needs we've heard within the group. Any questions? So we are back on track. Thank you for talking fast and getting us back on track. 4 minutes. Does anyone have anything they would like to share in the last 4 minutes that we have? Good work that's going on. Time to brag about your organizations or your employees in your organizations, programs. Did everyone see Loretta's TV debut on Drug Court?
Yes.
I will send that out.
Oh, awesome.
It's nice. She did a.
Get her signature.
Go ahead,
now.
Loretta.
Or she can say that she doesn't know any of it.
Go ahead.
It was just, it was a little piece on Drug Court, and it involved the entire team. It wasn't just me. It had the judge and the prosecutor's office, public defender's office, and then treatment. So just kind of the real stars of the show were the two patients that from drug court that were interviewed and talked about their experience and how different it was to be in court and have positive feedback, positive experiences, and how they felt like that the team was wrapping around them and actually looking at their needs and what they needed to do to be successful. And some of that was really creative around transportation. One gentleman had a health condition that he hadn't looked into, but had really been bothering him for a number of years. And so that was one of the judge's requirements of him, was that he go to the doc, get that checked out, and bring that back and report on that in the next 2 weeks. And turned out to be absolutely nothing. And so that was a positive experience for him. Visiting with children, and someone moved into an apartment, and so a group gathered some things to be able to give to him, to be able to put into his apartment. He'd never had one. Young 30-something-year-old, and never had an apartment on his own. So one of his highlights was he realized that a shower curtain is a really good thing, something that he hadn't thought of. So, just being able to have that experience with him, it's really a highlight.
Greta?
Wendy, can I say something?
Sure.
Catholic Charities is going through a reorganization.
Do you have your mic on?
Hi, this is Chris DeVolnu. Catholic Charities is going through a reorganization process. Chris Davis is taking a new position, has resigned from Catholic Charities. Susan Marnie is now our interim director, and we're doing a lot of work on some changes within the agency, and we'll send out information on that soon.
Thank you.
It wasn't an April Fool's joke.
Anything else? Okay, last two announcements. Don't forget the VBP rural multi-payer model discussion happens in this room at 1 o'clock, starting at 1 o'clock, and the annual